Okay, good morning and welcome to Health Talk here on AM 1270 and 96.5 FM KXBX. We are Paul Thomas and Bill Curdy of Northlake Medical Pharmacies. Bill, how are you today?
I'm doing great. I love that weather out there. It's I went by a bunch of places yesterday and everybody was mowing their lawn and whoops.
No, we're there. I'm just make sure we're on the air. I'm
Okay.
going to monitor us live on the air this week so we make sure we got your microphone on.
I have a lot of snow on mine.
It's going to go away here in about 2 seconds.
Oh, it did. Okay, right. I thought, no, the weather's changing. It's snowing
No,
again.
it's not snow. Just a little static. I just wanted to make sure we're both on air. So.
Well, we are, and it's good to be here, and it's good to see that sunshine out there. And I actually started heating my pool so I could start swimming, and then the heater quit. So now it's another excuse not to work out, and so I'm.
What are you going to do?
I don't know what I'm going to do. I guess I have to quit eating or running or something. I saw the surgeon a week ago and said, he gave me a cortisone shot and said, just keep doing what you're doing. And so we'll do that. I have an interesting part to, I'm in and out here again, interesting part to healthcare today. My wife has been diagnosed with having a torn meniscus and no cartilage in her knee and a popliteal cyst and bone on bone. And so we went to the surgeon to see what had to be done. And he said, well, you need a new knee. And Anna said, well, that's good. The pain is just incredible. And he said, well, that's the good part. You need a new knee. The bad part is because of Medicare, you can't have a new knee unless you go through all of this protocol required by Medicare. So he gave her a cortisone shot and said, okay, this is the first step. The next step is a month's worth of physical therapy. Yes, we know it's bone on bone, and we know it's not going to get better, but Medicare won't pay for it until we go through this. And then the next step is to have 3 injections of Synvisc, which is supposed to promote cartilage growth, but he said it won't. And then after 6 months of this, you'll qualify to have a new knee.
Wow.
And she said, don't I need it now? And he said, oh, yeah, there's no question that you need it, but the insurance will not pay for it if you don't go through Obamacare's policy on getting a new knee if you're on Medicare. So,
and how many different stops along the way did you say that was? At least 3 or 4?
Well, first was the injection of the cortisone, which didn't do anything because it's bone on bone.
Sure.
There's nothing to get inflamed. The incisions were where the meniscus is torn. We looked at it on the X-ray. There's nothing we can do, he said, because they won't pay for that either. The cartilage is gone, but we have to go through this protocol to satisfy. So that was the first thing. Then the second thing is a month's worth of physical therapy and then be reevaluated. The third thing is 3 injections at I don't know what time interval to take Synvisc to see if more cartilage will grow. And the fourth thing was to take glucosamine and chondroitin to stimulate some growth in there. And the fifth thing is the knee replacement. But we have to do those other 4 things first.
Wow.
Even though there's nothing there, and it's going to be a painful time element in there because there is bone on bone, and it's very frustrating on what we've been talking about for a long time, Paul, and that's the state of healthcare in this country. The people that really need it aren't the ones that can get it. And especially if you're getting older and if you're in the Medicare age group, it's all kinds of things that you have to qualify in order to get additional health care. So that was kind of a disappointment to both her and myself when we went down to see the surgeon. And although he admitted that it needed to be done and it would probably last 30 years, which is more than our lifetime, because the newer prosthetic devices are are very good compared to the ones we used to have to replace after 5 years. So, but this is about Health Talk and about your health. Our number's 263-5252. If you have any questions about your health, be sure and give us a call. There's a lot of things that we need to talk about that came up in the news. One of the things that we probably don't really want to talk about, but we need to talk about, is the End of Life Act that was passed in October in California. It will go into effect the 9th of June. If you watched 60 Minutes last week, you saw where people had moved from California to Oregon because they could end their life if they were terminally ill, and go through the process. And it was kind of eye-opening to me to see what that process is, and I downloaded all the requirements, which are quite extensive. A terminally ill adult with the capacity to make medical decisions may make a request to receive a prescription for an aid to dying medication under the following circumstances. If their attending physician diagnosed the individual with a terminal disease, the individual voluntarily expressed the wish to receive a prescription for end-of-life dying. The individual is a resident of California and is able to establish residency following possession of a California driver's license or other identification, registration to vote, evidence that the person owns or leases property in California, and filing of a California tax return. So the individual document his or her request. It's the individual's has the physical and mental stability to ingest the aid in dying medication. Now, what I found. Did you see the 60 Minutes, Paul?
I did not know.
They had a physician from Oregon that aided in the dying of this patient who.
I remember the story.
Who moved.
It was a national story.
Right, and it was interesting to me on how it occurred. They write a prescription in Oregon for 100 secobarbital, which in my day that was called Seconal. It was a barbiturate that was used for sleep aid, and a quite strong one. They had pentobarbital and they had secobarbital, and then they had a mixture which was Tuinal, which was seco and pentobarbital in one. The patient is required to take all 100 capsules and open them up and put them in a powder into a glass, and then add so much liquid, and then drink the whole thing. And what is supposed to happen, and what usually happens, is within 5 minutes that individual now the normal dose is one of those at bedtime. Now they're taking 100 in suspension. In 5 minutes they are just sleeping, and in 30 minutes they have ceased breathing. There's a few things that happen. Number one, you have to have more than one physician agree that it's okay for her to take or him to take the aid in dying drug. They have to see the physician 15 days apart the first time, and then 15 days later directly to his or her attending physician, and the request must be signed and dated in the presence of both witnesses by the individual seeking the aid in dying medication. The individual has to be personally known to the witnesses. The individual voluntarily signs the request, and in their presence, the individual is of sound mind and not under undue influence, and the witnesses are not the individual's attending physician or consulting physician. So only one witness may be related to the qualified individual by blood or marriage. And it continues on with more directions. California is very similar to other states. The two physicians must respond to each request. The attending physician is defined by the Act as the physician who has primary responsibility for the health care of the individual. So then they get the medication, and they take the medication. And what happens in a large percentage of the time, the prescription is filled for that individual, and many times it's not used. They change their mind, which is what they can do. So the problem with this is the physicians that have to accompany this request are used to treating people to get them better. Now all of a sudden, you're going against the Hippocratic Oath and you're aiding them in dying. And that's a huge personal decision for people, and it's not easy to determine who that person will be in California or who that person will be in a medical community like this. We have a problem in rural areas like this of having family practitioners, whether it will be a hospice physician or but the physician has to be a family physician that knows them. So it can't be somebody that you go into the ER and present a request for, and then they write the prescription, and then another physician consults with it too. So there's an attending physician and a consulting physician that has to be involved. Now this isn't in effect yet in California. It will be starting June 9th. So people would still have to go to another state that accepts end of death, and then they would have to establish residency. And so by the time that would happen, the California law would be in effect. It's an unusual scenario to see, and one had suffered from a long episode of trying to get better, and her son was with her all the way on end of life issues because he didn't want to see her suffer anymore, and she didn't want to suffer anymore because of it. So it's a huge step in. It's a difference. What we call palliative care, which hospice does, which treats individuals when they're dying, and perhaps they go into an end-of-life coma, per se, and they eventually pass away. This is an immediate death that occurs. Again, in the California law, I don't see the protocol on what the drug would be. I don't know whether pharmacists would be dispensing that medication. Again, we used to prescribe or dispense Seconal and pentobarbital all the time, but it has pretty much ceased. It's a Schedule II drug that would have to have a special authorization, I would assume, if it says take this all in one dose, because we know it would cause death for that individual.
Is it all oral, or is it?
It's all oral. They actually buy 100 capsules, and they have to pull them apart, each capsule, and put them in a drink, and then drink it down.
So that just knocks you out, though.
No, it actually kills you. The first 5 minutes you're just sleeping, and you sleep for about 30 minutes, and gradually your respiration gets lower and lower, where you're not breathing as much, and then eventually you stop breathing.
So who decides which patients get this and which patients don't? Because that's up to obviously your doctor. But
well, you have to have two physicians agree. One has to be your family physician, and one has to be a consultant physician, and you have to see them 15 days apart from the first time you see them, and you go back after 2 weeks and say you still want to do this, and where we get the physicians that say they're comfortable doing this, remember, when we go to medical school, we are taught to take care of people. Mm-hmm. We're taught to get them better. Now, getting them better happens to be ending their life. Mm-hmm. And that's a huge decision. I've had many of my patients say, Bill, will you give me something to end my life? And I say, I can't do that. I can't, even relatives. And I said, it's against the law. I'm sorry that you're feeling that way. And a lot of them are just afraid to die, and they don't want to go through the procedures of, you have to have a terminal illness. You have to have a documented record that it's terminal and there's no help for you getting better. And a lot of these people are going through chemotherapy and radiation, year after year after year, and they're deteriorating. And there is no hope for them not to eventually die. This is just ending.
But the girl who went to Oregon, I mean, she had a terminal illness. It was a brain tumor or something, right? But she wasn't in, I don't know how to word it here, decomposed state, or she was still physically able to move around, and it was pretty active, I think, at the point when she died.
She was having lots of seizures.
Oh, was she?
Okay. And the tumor was growing abnormally fast, and there was nothing they could do to slow it down. She knew eventually that she would lose her life, and to be going through the seizures and repeated seizures like that and not be able to control it.
I wasn't aware of the seizures. So.
And it was, and I think that we have to be very careful in the future with this, and make sure that that this is the truly end of the life, and they have to be mentally stable. They can't just. But it's a whole new era in medicine that we need to think about, and again, the whole purpose of this is to give that person a quality of leaving this life, not to put them through more hell as far as the kind of therapy they have to go through, or the side effects of the medication, or the fact that the medication isn't doing any good. I read an article the other day where some sort of it's almost like a cell replacement, and they were treating circulatory cancer where it was in the bloodstream, and they had a 97% cure rate. Now they're trying to do that with actual tumors and see if it's effective. And so there's things on the horizon that may prevent a lot of this from happening, but there are plenty of people that are hanging on in situations that they know they're not going to get any better, and they don't have any quality of life. And this brings up an interesting thing. What about the person that has the stroke that's just in a coma and healthy otherwise, or a person that has Alzheimer's disease that doesn't even know who they are anymore? How black and white is that law, and how gray is that law? So there'll be more and more coming in the future. We had passed the bill in October, and it's just now becoming effective the 9th of June. There'll be a lot more publicity on how this goes about and what we need to do and who needs to do it. And there's all kinds of things on the internet for consent forms and all those kind of things. So that will be coming. Congressional sources have been informed that this is going into law, not in every state, but many other states have it. And we have to address it and provide the right criteria in order to let it succeed, because there are many people in California who are waiting for this to go through. Again, our number is 263-5252 if you have any questions about anything we're talking about. Paul, this was for you.
All right.
What happens if you eat the food that fell on the floor? I thought we'd
I don't know, a 5-second rule in place?
Yeah, I mean, have you done it?
Have I eaten food off the floor?
Mm-hmm.
Sure.
Well, you're preparing dinner, and
yeah, I drop mushrooms and I pick them up and I'll rinse them off and eat them. Yeah.
The tomato slice slips off the cutting board, and you haven't mopped the floor in a month.
Mm-hmm.
So you've just been outside in the mud, and
yeah. No.
You scoop it up, throw it back in the salad bowl because nobody's looking, and
Yeah.
aren't you supposed to be protected by the 5-second rule? But
5-second rule.
really what we're worried about is the strain of Salmonella or E. coli or other bugs that can all lead to food recalls. And after all, you've been trampling on that floor in your shoes. You don't even want to think about all the subway streets and cities. I mean, if you ever walk down in San Francisco. But the very worst thing that could happen is you're allowed to say, I told you so, and it turns out that the food does pick up some germs upon making contact on the floor, and the amount of bacteria can be enough to make you sick. But usually what's happened is before you freak out that bacteria on your food becomes a problem, it's only if the stuff on the floor are actually the kind that make you sick. For example, Salmonella, your food would have to fall directly on top of those bugs and to really transfer the bacteria. That isn't necessarily on your kitchen floors. You have to bring contaminated food from someplace else. But if you do have contaminated goodies at home, it's actually pretty easy for bacteria to end up on the floor. What will probably happen is nothing. The odds are extremely low of you getting sick from eating fallen food. I can remember when I was a kid and we'd be outside playing, and you get an ice cream cone or a banana or something, you drop it in the dirt, and you just pick it up and eat it.
Yeah.
And since the majority of the food you bring into your kitchen isn't contaminated, you'll likely be just fine if you eat a slice of toast from your kitchen tile. But to minimize your risk, consider staying on top of the food recalls. And if you hear a product is being recalled for bacterial contamination, which we don't pay any attention to, usually you can toss it before it has a chance to infect your floors. Of course, if you do your floors once a month or once a week, it probably isn't too bad. But there was a study that went on in the Journal of Applied Microbiology with this research scientist to test this. He and his team dropped slices of bologna and bread onto the floor, contaminated with salmonella. He let them sit for various amounts of time and recorded exactly how many bugs moved from the floor to the food. When the edibles were dropped on wood or tile and left there for 5 seconds, anywhere from 48 to 70% of the bacteria from the floor made it onto the food. Score 1, though, if you're the rare person has carpeting in your kitchen, because less than 1% of the bacteria were transferred to the food dropped on the rugs. Now, that really surprises me, because if you have a carpet in your kitchen, unless you're really an impeccable person, I mean, there's all kinds of food on that carpet. So that reminds me of a story. When I was in Chicago, I rented an apartment in 1130 North Dearborn Street, across from the Playboy Club. And one of the bunnies had this apartment that I was rented, and it had a beautiful orange and brown carpet in there, and it was, remember these deep shag carpets?
Oh, yeah.
So
cozy to lay on.
I went to Europe on a ski trip, didn't even know how to ski, and I came back. We left in March and came back in April, and I opened the door, and it smelled terrible, like cats had been in there or something. So I called a carpet cleaner and cleaned the carpet, and the carpet had cat poop in it. That was the brown spots. It was an orange carpet. And I don't know how many times I laid on that carpet. I was a bachelor. I was living there by myself. And I thought, who could live in this with a cat that had not practiced good toilet habits, and
but maybe it made your immune system stronger.
Well, it could have been. When I went to Vietnam and Korea, I ate everything over there and I was on the DMZ in Korea, where they would bring up fresh fish, but it would take them a couple of days to walk up there, and they'd wrap it in newspaper. By the time they got the fresh fish up there, it wasn't fresh anymore. But we ate it anyway, and nobody got sick.
I strongly believe the body will adapt itself to those kind of situations,
I think unless your immune system is just susceptible to compromise with that kind of thing, you do. But I have managed to
It's like it's like the my grandson at home. He's a year old, and he's walking around, so everything he picks up goes in his mouth, and
Yes.
his mother just freaks out, and it's like, look, a little dirt in the mouth is not going to hurt. He's going to build up, some sort of a immunity to it. You keep him in a bubble his whole life, then I'd be worried about him.
We used to have, at my house, ashtrays in the house because my dad smoked Camel cigarettes.
See where this is going.
And we'd go around and lick the ashes out of the ashtray. I guess we had some sort of deficiency, but we're going to take a break, and when we come back, we're going to talk about how you can eat to beat psoriasis. Did you know that according to the American Heart Association, heart disease is the leading cause of death among men and women in the United States? Hi, my name is Bill Kearney, pharmacist and owner of Northlake Medical Pharmacies. The good news about the heart is that a healthy lifestyle can prevent the vast majority from the disease. There are risk factors that you can't change, such as being male, being older, and a family history of heart disease. But other risk factors that you can change. Smoking. Do you know that 30% of all the deaths from heart disease are directly related to smoking? High cholesterol. Limit your fat intake and limit intake of cholesterol. Increase your intake of vegetables and fruits. Exercise routinely and drink 32 to 64 ounces of water daily. When these things are done in combination, they can drastically reduce your chance of developing heart disease. While these procedures are very important for people with risk factors, they're even more important if you've had a heart attack. Northlake Medical Pharmacy with 2 locations for you, and now free delivery to Lakeport, Nice, Upper Lake, Lucerne, and now Kelseyville, the Rivieras, and Buckingham.
You're a 19-year-old kid critically wounded in the Central Highlands of Vietnam. Your unit is outnumbered 8-1, and the enemy fire is so intense that your CO has ordered the medevac helicopters to stop coming in. Your family is halfway around the world, and you're thinking that you'll never see them again. Then you hear the sound of a helicopter. Captain Ed Freeman is coming for you. He's not medevac, but he heard the radio call and decided to fly down into the machine gun fire anyway. Then he flies you up and out to safety, and he keeps coming back 13 more times until all the wounded are out. No one knew until the mission was over that the captain himself had been hit 4 times. Medal of Honor recipient Captain Ed Freeman died in Boise, Idaho. We're losing about 285 Vietnam veterans every day. But the Education Center at the Wall will preserve stories like these so future generations will understand and never forget. Call 1-866-990-WALL or go to buildthecenter.org and help us build it.
The following is a public service message from this station and calltorecycle.org. Chances are you already recycle paper, glass, and plastic, but it's just as important to recycle used rechargeable batteries. They're the kind you find in power tools, cell and cordless phones, laptops, and other cordless electronics. It's easy and it's free. To learn more, call 877-2RECYCLE or visit us online at calltorecycle.org. Just remember, if it's rechargeable, it's recyclable.
I wanted to be in the military since I was a kid.
I served in the United States Air Force.
I served a total of 16 years.
I was deployed 13 times.
On my second deployment, 4 bombs hit my vehicle.
And at 19 years old, that's the first time I ever saw somebody die.
Coming back, I was raging.
I started having pretty horrible nightmares.
I would wake up in the middle of the night, sweats.
I started drinking a lot.
I felt worthless.
I guess I never recognized it in myself.
Eventually, one day I just walked into the VA hospital and said I'd like to see somebody.
Don't suffer alone. You gotta find that link with somebody that'll make you let it go.
It all starts with going to the VA. There's a whole community of veterans that just want to help you out.
It's for the guys who couldn't come back, so you owe it to them to live well, because they're not here with their families.
Visit maketheconnection.net.
And we're back.
We are, and before I get started on psoriasis, I need to remind you that we have the children's vitamins, free children's vitamins at the pharmacy. If you come in and fill out a questionnaire, each one of your children from age 6 or 2 to 12 or 6 to 12, I can't remember the age requirement.
2 to 12, I think it was.
Can get children's vitamins free. You'll get a card, and each month you'll get a new bottle of vitamins for your children that for each one of your kids that doesn't cost you anything. So be sure and come in and do that. We want to also remind you that I have a bass tournament coming up this weekend, the Clear Lake Chamber Team Bass Tournament. I've sponsored from day one, and probably 100 and some teams. It'll be out at Konocti Vista. The weigh-in is at 3 o'clock on both Saturday and Sunday. I'll be there for the blast-off on Saturday, and then the weigh-in, I'll miss Saturday because I have a funeral, and then I'll be there Sunday for the weigh-in. This is usually a great bass tournament, usually some great weights. The weather will be warming up. The lake is full. Love to see you out there supporting our community, and a great weekend for bass fishing. Also, I'd like to say it's Happy St. Patrick's Day tomorrow,
yes.
so to be drinking a little bit of the green beer and telling everybody that God is with them, and to keep their knickers on and not get in any trouble. So
When you're green, right?
Eat plenty of corned beef and cabbage, and drink a little bit of the spirits, to keep the bad people away, and we'll be happy to be celebrating St. Patty's Day. So.
Saturday was my birthday, and so my wife said, "What do you want for your birthday? What do you want to eat?" And I said, "Well, I'll do corned beef and cabbage," and I cooked it, which it's funny how it's my birthday, but I didn't complain. But there is a fine line with corned beef and cabbage. I must warn everyone.
You can overdo it.
You can overdo it.
Yep, you
and
can.
it got overdone. And my sandwiches just aren't as good.
Oh, and I love that little bit of fat on it that makes it.
Oh, you got to have it. And you read the directions, and it said 50 minutes per pound, and I had a 3-pound corned beef cabbage. So I thought, okay, well, that's, 150 minutes over 2 hours. I set it for 2. Don't believe what you read, folks.
Really?
No, it was overdone at 2 hours. So
wow.
Yeah.
Well, we'll eat it anyway. So
that's my public service.
Yeah, those are great sandwiches too. So, okay, we talked about what can you eat to beat psoriasis. I don't know how many people you know that have psoriasis, but I know a lot of people that have severe psoriasis, and there are medications out there now that will treat it and do an excellent job, but they're horrendously expensive. So. I saw this on the internet. It says, what can you eat to beat psoriasis? And a balanced diet, of course, is good for almost any kind of disease. But fish, the benefits of fish, fatty types of fish such as salmon, albacore tuna, herring, lake trout, and sardines are high in omega-3 fatty acids, and those help fight the inflammation that's really characteristic of psoriasis. There's stronger evidence that eating fish is good for your heart, so the American Heart Association recommends consuming fish, particularly those fatty fish, at least twice a week. Of course, there's always that danger of mercury contamination, especially in those fish, but your heart and blood vessels will thank you for that fish fillet. And what about wheat? Some people will, with psoriasis, might have allergies to wheat, which is why they want gluten-free diet sometimes, but if they're sensitive to gluten. So, but it supports this theory that psoriasis patients had increased levels of certain antibodies in the blood that actually works against signs of gluten sensitivity. So if you have both psoriasis and gluten sensitivity, a gluten-free diet might help control your psoriatic symptoms, but that type of diet also rules out wheat, rye, and barley, which are found in normal bread. So, are you a bread eater, Paul?
I do like. I like rye bread a lot.
That's my favorite, rye bread. I used to eat wheat bread all the time, but I really like rye bread.
Gotta have rye.
And
dill rye. I love dill rye.
I don't know that I've had dill rye.
You never had the dill rye?
No.
Ooh, that's good stuff.
Some people report that red meat or fatty foods aggravate their psoriasis. There isn't any research really that says that, but it's possible that food triggers something from person to person. We find out that, especially in psoriasis, even other disease states, that what aggravates one's disease doesn't aggravate another's disease. So it's different with everybody, and you can generalize many times and think that it's going to be fine. But everybody, that's why I always tell people that we're individuals. Some people come up to me and say, can you have paralysis or lose your feeling in one of your arms by taking this medication? And I says, certainly you can. It's not in the side effects from having it, but everybody has an unusual response to medication, and that's why we always go back to this risk versus benefit thing. So what will dramatically cure one person's disease might not cure your disease. So or the side effect can be much greater and the risk is much greater, and if the risk is bigger than the benefit, then you certainly don't risk it. Remember Maria Sharapova, the tennis player? Did you see where she was taking?
I saw she took some sort of a bad thing.
She took meldonium, which is a drug that she was taking for what she thought she was taking it for. What she told she was taking it for was to aid in her heart circulation, but it's prescribed elsewhere other than here to help protect heart disease by regulating the metabolism, and also has been used by neurological clinics to treat patients who have asthenia, which is an abnormal lack of energy. So in January, Maria had been taking this drug for 10 years. They put it on the World Doping Agency started monitoring the use of the drug by athletes in 2015 and banned it outright beginning this year. Her drug sample was collected on January 26th, and she had it in her system. And it also is used like some of the erythroproteins, like what Lance Armstrong was taking. It demonstrates an increase in endurance performance of athletes and improved rehabilitation after exercise, protection against stress, and enhanced activations of the central nervous system. So they actually have suspended her from participating. She was the highest paid female athlete. She came up to the microphone and said that she failed a drug test, and she's sorry. A lot of people don't believe her, that she knew all the time that it was an enhancing drug, and that she, even though they don't have it in this country, she knew that that it was something that was going to aid her, even though it protects heart tissue.
I think that any athlete that is taking any kind of a supplement, a performance enhancer, a powder shake, anything like that, muscle builder, weight loss plan, any athlete that is taking any one of those things is doing it for better performance. That's the whole reason why they're taking any of those things. Sure
it is. And I mean, it's like people taking Adderall to do better on exams. Mm-hmm. Adderall is an amphetamine-like substance that stimulates the brain, and now kids in college, in order to take a test, they're getting a hold of Adderall. There's actually a movie called Adderall Diaries, where in order to be competitive, they feel like they have to take the medication. Wow. And I have said on this show before, I took it as an experiment. It wasn't that exact drug, but I was doing a essay on amphetamine use in college students, and I actually took the drug to take an exam, and when I came out of the exam, I thought I did marvelous. But what it does, and this is going against meldonium, but it's another enhancing substance for other than athletic performance. This happens to be to aid you in taking exams. When I went through the exam, I came out of there and I knew every answer. But your brain functions faster than what you can mechanically write, and I had left complete sections out of that exam that I thought I had written the answer to and didn't, because I did it in my head, but I couldn't I couldn't write it as fast as I could think it. So it definitely has in a optional test where it's multiple choice. You probably do much more. If you have to be writing down information, it's probably a lot more difficult for you. So I agree with you, Paul. There are those. Everybody should be on the same page. As time goes on, we find extra ways to beat the system, and the actually results are drastic when you find out that you're trying to beat the system illegally. She lost tons of money by sponsors. Everybody pulled away from her as soon as this happened. The same thing with Lance Armstrong. The same thing with any athlete that you find out they're using enhancing substances has they've lost all their endorsements. So yesterday, the CDC, the Center for Disease Control, issued new guidelines on opiate prescribing to reduce abuse and overdoses. Now, the CDC is a federal agency, but it isn't an enforcement agency. So they warned doctors yesterday to use caution when prescribing drugs for chronic pain, to carefully monitor the patients using the medications as part of an effort to reduce addiction and overdoses. We have, as you know, if you've listened to me on this show, a huge epidemic of people with Norco and oxycodone, and nearly all the prescription opiates on the market are as powerful as heroin. And yet prescription opiates often do a very poor job. And the longer you take them for chronic pain, the less effective they are. For the vast majority of patients with chronic pain, the risks aren't worth the benefits. That's awfully difficult to tell a patient who has a condition, a chronic condition that they have to treat. And there's no other medication used for non-fatal conditions that kills patients as frequently as these opiates do. So the United States is in the grips of an epidemic of painkiller abuse, with 40 Americans a day dying from overdoses.
40 million?
40 Americans a day.
40 Americans. Okay, yeah. Gotcha.
In 2013, an estimated 1.9 million people abused or were dependent on prescription opiates in the same class as morphine. So we keep seeing the screws tighten on these as far as the pharmacy goes. The hard line on opiates is a major shift from conventional wisdom about relieving pain for decades. Doctors were told to consider pain as a vital sign that needed to be addressed, and that's when all of this started. So the CDC's 12 new guidelines are intended for primary care physicians who prescribe more than half of the opiates. What they recommend, the aim is to help determine when to begin or continue for chronic patients, how to choose opiates, for how long, and how to value and risk the harm. The recommendations, which doctors aren't legally obligated to follow, don't apply to the treatment of patients treated for cancer or those receiving end-of-life palliative care. So doctors should use therapies other than opiates for such as exercise or non-steroidal anti-inflammatories. I can tell you, someone who lives with chronic pain all the time, is I'm never out of pain. I take an anti-inflammatory, which is Celebrex, which lessens the pain, certainly. Instead of a throbbing pain, it's just an aching pain, but it never goes away. But if I was on opiates, which I was after my surgery, and I took it for roughly 30 days, and I gradually decreased the dose to where I think I have 6 left, and I've had those left since the 1st of February. But these are drugs which are like Vicodin and oxycodone, and they don't want them to prescribe benzodiazepines at the same time, which are anti-anxiety drugs like Valium and Xanax. And if the FDA sees this, even though there isn't a law that says you can't, and the DEA, they will pull the files and say that you shouldn't have been filling them. It's called a cocktail. When doctors do prescribe, they should use the lowest effective dose for the shortest amount of time. So instead of prescribing long-acting OxyContin, they're to prescribe the short-acting drug for a short amount of time. And usually after surgery or those kind of things that's caused by an injury, they don't need opiates more than for 3 days. When opiates are prescribed, they're supposed to start low and go low, meaning that the doctor should increase the dose of medication slowly and only if it's needed. So, again, these aren't laws yet. It's not regulations yet. It's suggestion by the CDC. And then they suggest that doctors check every 3 months to see if the benefits still outweigh the risks. If patients abuse the opiates, doctors should help them get off the treatment that's supported by strong medical evidence. They should ask questions if their doctor wants to prescribe them opiates. What are the risks? What are the benefits? How long should I take it? Is there an alternative? What can we hope to accomplish by using an opiate, and how will you know when you've met our goal? So when considering long-term opiate treatment, they suggest that the physicians set realistic goals for pain, check the non-opiate therapies that are tried and optimized, discuss benefits and risks, addiction, overdoses. Remember, part of the problems with people who end their life with these things are they may have been on these long periods of time, and then they've been off of them for a while, and then they go back and they start back at the dose they were on when they were tolerant, and they die. And especially if they use a fentanyl or a benzodiazepine with them, they just go into failure and they can't breathe anymore. So, when you go into a doctor's office, every time I go into therapy, they said, what pain level are you in? I always say 2, because it's never less than 2. When I first got out of surgery, I would
more than 2.
I would say 10. By the time I'm out of therapy, I'm up to 9 or 10. So there needs to be criteria for stopping those steroids or stopping those opiates. Steroids are an example. Last week I did get I told the surgeon that the pain had been incredible, and I'm happy to say the surgeon didn't say, do you want more Percocet or something like that? They said, no. I didn't ask. But they said, how would you like to try a shot of cortisone? And I said, I'm up for anything other than the opiates. I mean, I can't work and take that kind of medication, and I don't like the way it makes me feel. And it doesn't really control the pain. It dulls the pain, but it doesn't control it. Actually, when you take a steroid or a non-steroidal anti-inflammatory, it treats the reason that you're having the pain. It treats the inflammation. When you take an opiate, it just tells the brain it doesn't hurt, but it doesn't do anything for the reason that it's hurting. So the other alternatives, the steroids, and there are side effects from steroids. There are side effects from every medication. There are side effects from taking the non-steroidal anti-inflammatories. It can eat your stomach up, but it's a whole lot better than taking an opiate. And eventually, there's evidence that short-term benefits are small to moderate for pain, inconsistent for function, and then as time goes on, it becomes less effective. So there'll be prescription monitoring programs that check for opiates or benzodiazepines in your system, and there'll be urine drug testing. There'll be a lot of guidelines with this when you're taking opiates that never were before. And right now, like I say, these are all, this just came out yesterday from the CDC, guidelines for prescribing the opiates for chronic pain. So it's a bunch of recommendations that for sure the DEA and the state and federal legislatures will put into law, making sure that they're being followed so we can stop this epidemic. 3 most addictive drugs, according to Addiction. You have any idea, Paul?
3 most addictive drugs. I'm going to go with oxycodone or Oxycontin, whatever they call it, heroin, and let's say alcohol.
Actually, it's heroin, number 1, alcohol, number 2, and cocaine, number 3.
Cocaine, number 3.
Powerful addictions. So, and you can get all of those substances here in Lake County for just a phone call. And
you sound like an advertisement almost. Just a phone call away.
We hate that. We don't like that at all. I just want anybody to know, because heroin is less expensive now than the oxycodones, that it's highly, highly, highly addicting, and you never reach that pinnacle of height that you had the first time. It will never, never, never come back. So stay away from it. As you know, today, the availability of substances like that has just become dynamic, and especially with the opiates out there, a lot of people are converting into those things, and that's the road of no return. So please don't get involved with that if you can help it. I want to remind you that flu season is still here. The vaccine is good until the end of March. I mean, the injections. In April, they become out of date. So if you haven't gotten your flu shot yet, let's get it. Let's get you protected. We still have almost a couple of weeks left to get your immunizations. I think we have 8 shots left. And it's something you need. If you haven't got your Zostafax yet for smallpox or for shingles, please talk to your physician about getting it. You don't need a prescription for it. You can come in. Very expensive. You have to pay for it unless it's covered by your insurance. Well, we'd like to remind you we're Northlake Medical Pharmacies with 2 locations for you at 5136 Hill Road across from Sutter Lakeside Hospital. Call us there at 263-6192. And outside the Bruno Shop Smart at 347 Lakeport Boulevard. Give us a call there at 263-1328. And happy St. Patty's Day to you.
All right. We'll see everybody back here again next Wednesday for Health Talk. Right on here on AM 1270 and 96.5 FM KXBX Lakeport.